Respected physicians and dear participants, welcome you all to today's sessions on basics of CT in stroke. খুবই ইম্পর্ট্যান্ট একটা টপিক। আমাদের সবাইকে আসলে কম বেশি জীবনে স্ট্রোক পেশেন্ট ফেস করতে হয়। আসলে আমাদের এই সেশনটা যেটা টার্গেট, আমরা চাচ্ছি একদম বিগিনার্স যারা জেনারেল প্র্যাকটিশনার্স থেকে ইন্টার্ন অন্তত স্ট্রোকের বেসিক সিটি স্ক্যানগুলো যাতে রিড করতে পারে বা বুঝতে পারে এবং ইমার্জেন্সি কতটুকু এইটাও যাতে এই সম্বন্ধে ক্লিয়ার একটা কনসেপশন হয়। এবং আমাদের ডাকে সাড়া দিয়ে যথারীতি আমাদের বিডি ফিজিশিয়ানস ফ্যামিলির, আমরা যাকে বলি মানে আমি তোমাদেরই লোক এই হোক মোর শেষ পরিচয়, আমাদেরই লোক ডক্টর প্রবীণ কুমার যাদব, সিনিয়র কনসালটেন্ট নিউরোলজিস্ট অ্যান্ড অ্যাসিস্ট্যান্ট প্রফেসর অ্যান্ড চেয়ারম্যান আরোগ্যম নিউরো ক্লিনিক আমাদের মাঝে উপস্থিত হয়েছেন। Dr. Praveen Kumar Yadav did his MD in General Medicine, DM in Neurology. He got double MRCP and double FRCP from UK, London and Edinburgh. He also did FEBN from UK and recently awarded Fellowship of Indian Academy of Clinical Medicine. So, Dr. Praveen Kumar Yadav, আপনাকে ওয়েলকাম এবং যথারীতি আয়োজনে আছি আমরা বিডি ফিজিশিয়ানস। আমি আর কোনো ভূমিকা না করে আমি ডিরেক্টলি হ্যান্ড ওভার করছি to Dr. Praveen Kumar Yadav.
Thank you, Dr. Ahsan Khan, for the introduction, and thank you for this opportunity. Today I will be dealing about CT scan in stroke patients. Now we all know that stroke is a very important situation, and we face stroke patients in general OPD, in emergency, in critical care setting and all. So everybody should have a basic idea of stroke. So today I will be briefly talking about stroke and CT scan, and my presentation will be practical oriented. That means I'll not go into much of the technicalities of the CT scan or the physics of CT scan, but directly go into the practical implications of CT scan, what we can do and how do we interpret a CT scan and all. I'll be speaking on trauma also, because that is again a common scenario which we all see in the emergency setting. So I'm going to share my slides. So is it visible?
Yes, sir.
Slide টা দেখা যাচ্ছে?
Yes, sir, visible.
Load হয়ে গেছে?
Yes, sir.
Okay. So before going into the CT scan, the most important thing in CT scan is Hounsfield unit. So this is the basic unit of CT scan, and we decide whether the lesion, whatever lesion we are seeing in CT scan, whether it is hyperdense or hypodense according to the Hounsfield unit. So what we have to know is that the CSF Hounsfield is 0 to 10. So that is the basic Hounsfield, and white matter, gray matter, blood and calcium, they're having more Hounsfield units. So the maximum Hounsfield is for the bone. So when we see the CT scan, I'll show you the next image. The bone will look white. So that is the maximum Hounsfield. It comes around 600 to 1000. Then blood. If there is blood in the CT scan, that will be again bright or white. So that is the second highest Hounsfield, around 60 to 80. Then comes gray matter and white matter. And CSF is dark, as we all know. CSF is dark. And fat will be more darker than the CSF, and air will be the darkest. So this has the least Hounsfield of minus 1000. So if you look at this, this is the bone. So this is the skull. So here you are having a Hounsfield of around 600 to 1000. So this has the maximum Hounsfield. So it is dark. So this is the darkest structure which we see. After that, you can see the white matter. So these are the white matter, and this is the gray matter. So gray matter is around 35.8, and white matter has a lot of fat and myelin, etc. So the Hounsfield is less, 24.7. And this is the CSF. So CSF has a Hounsfield of 0 to 10. So this you can see it is dark. Now, if there is fat, so the Hounsfield will be lesser and air will be the least. So you can look at this. So what is this structure? So this is a muscle, that is the temporalis muscle. Just outside the CT scan, you can see the temporalis muscle here. After the temporalis muscle, you can see there is the scalp fat. So this is the scalp fat here. So this has a Hounsfield of around minus 80 to 100. So you can see it is dark. So it is darker than the CSF because it is fat. And this is the surrounding air. So it is the darkest. So air has a Hounsfield of minus 900 to 1000. So the CSF is dark, fat is even darker, and air is the darkest. So if you are having fracture and there is fracture of the sinuses, the air leaks inside the brain. So you can get, if you get this darkness of the air inside the skull, so that means there is a air inside the brain. Okay, so that is called as pneumocephalus. So that will be the darkest. And if CSF is there, that is intermediate. And if there is fat, suppose you are having a lipoma, fatty swelling in the brain due to some lipoma, etc. So that will be again be dark. If it is a dermoid cyst also, it is going to be dark. So that will tell us what the lesion is, whether it is calcium, whether it is CSF, whether it is fat, whether it is air. So briefly to summarize, CSF is dark and air and fat is even darker, and brighter are the bone which has the maximum brightness. Calcification, because it again has calcium, will be bright. Blood will be less brighter than the calcium or bone, and then you are having the other things. So bone has the maximum density followed by calcium. Sometimes we get calcifying granulomas, tuberculomas which have calcified, neurocysticercosis which has calcified. So that will again look very bright, more brighter than that of the blood, but less brighter than that of the bone. So that will be intermediate in nature. So if you look at this CT scan, so I've already told this is the skull. So this is very bright, around 900 to 1000 Hounsfield. This is the air which has a Hounsfield of minus 900. So this has plus 900. This is minus 900. Here you are having the gray matter which is around 35 Hounsfield. Then you are having the white matter here. So that is around 25 Hounsfield. And then this is the CSF, around 0 to 5 Hounsfield units. So this you have to know in order to interpret the lesion. So you can see here it's the CSF. This is the brain. The brain is the brightest and the air is the darkest. So air is more darker than that of CSF. Okay, so after going through the Hounsfield, we know what will be the intensity of the lesions. Now we have to understand that like in MRI, CT scan also has a lot of artifacts. For example, if you look at this CT scan, this is called as axial view. Axial view means the cut is being taken like this. So that is the axial view. And here you can see there is a darkish line here around the brainstem area. So this is the pons, and around this you are having a darkish line. So this is an artifact. It's not a lesion. So it's called as partial volume artifact. You look at this, it's a case of bullet injury. So you can see the metal is there here, and it's giving a lot of artifacts around. So this is a metal artifact. And here again, you can see there is a horizontal artifact. So this is again a sort of volume artifact. So you can get all sort of artifacts in the CT. So whenever you get a certain pattern of artifact around a certain line, so that means it is probably an artifact. So you have to, rather than reporting it as a hypodense lesion, you can say this is a horizontal partial volume artifact. So this artifact is also we have to keep into mind whenever we are interpreting the CT scan. Now going to the common planes which we use in CT scan. So this is the routine plane which we use, that is the axial plane. So axial plane, the cut is like this. You are viewing from above or below. So that is the axial plane. So you'll get the CT scan like this. Okay. So this is the axial plane. Now you are having the coronal plane. Coronal plane means this one. So if the brain is like this, you are cutting it like this and you are viewing it from anterior to posterior. So that is the coronal plane. And this one is the sagittal plane, in which the hemisection is like this. So it's cut like this and you are viewing from here to here or here to here. So that is the sagittal plane. So this is the sagittal plane. So three common sequences are used. Most commonly it is axial, but you can also use the coronal and the sagittal views. So why is it important that we use these views? For example, you take the CT scan. So this is the axial view, this is the coronal view, and this is the sagittal view. Now, if there is a lesion here, this is probably a meningioma. It's a brain tumor. So you can see in the axial view, you can see the lesion here, its relationship to the bone and the anteroposterior width. Now, if you're looking at the coronal view, you can find what is the depth of the lesion, what is the extent of the lesion in this setting. So in the axial view, you can see the lesion like this. In the coronal view, you can look from up and down. So you can know the exact extent of the lesion in the coronal view. So the different views can help us contribute to the anatomy and the spread of the lesion, whichever we are seeing. And this is a sagittal view. Sagittal view again gives the extent in this direction. And you can, this is the corpus callosum. Here there's the starting of the corpus callosum. So you can know what is the relationship of the lesion to the corpus callosum and the other structures as well. So that is the importance of sagittal view. So all the three views can be used whenever we want to see the extent of the lesion. Now, human brain anatomy, I think most of you are aware of this. So very important structure is the central sulcus. So this is the central sulcus here. Anterior to this is the frontal lobe. Posterior to this is the parietal lobe. You are having the sensory cortex in the posterior to the central sulcus, and the motor cortex is around the anterior to the central sulcus. Now, one important structure is the sylvian fissure. So here you are having the sylvian fissure, and below that is the temporal lobe, and this is the parietal lobe, and whole of this area is the frontal lobe. So if you find the key sulcus, that is the central sulcus and the sylvian fissure, you can find out the lobes which are there. If it is anterior to the central sulcus, it is the frontal lobe, posterior is parietal lobe, and below the sylvian fissure is the temporal lobe, and above that is the frontal lobe, and posteriorly it is the parietal lobe. So with this, you can differentiate which lobe the patient is having the lesion. Now, this is the CSF flow, roughly just telling you about the CSF flow. The CSF is produced by the subarachnoid, the choroid plexus, and the various villi in the choroid plexus, and it is then secreted. It comes up to the lateral ventricles. From the lateral ventricle through the it goes through the foramen Monro into the third ventricle through the aqueduct of Sylvius to the fourth ventricle, and then it gets from the fourth ventricle, it gets absorbed in the pile space and then goes out through the foramen of Magenda and the Luschka. The Magenda is medial and Luschka is lateral, and after that it goes into the superior sagittal sinus, from where they are absorbed. So this is the normal flow of the CSF. Now, if there is an obstruction at any level, so there will be an obstructive hydrocephalus. Suppose if there is an obstruction here below the fourth ventricle, then all of the ventricles, that is the fourth ventricle and all those structures, will be enlarged. If there is an obstruction at the aqueduct of Sylvius, then the third ventricle and the lateral ventricle will be enlarged, while the fourth ventricle will be normal in size. So if there is an obstruction, then we call it as an obstructive hydrocephalus. And if there is problem which is at the absorption level, that is at the absorptive areas in this superior sagittal sinus, then we call it as a communicating hydrocephalus. So obstructive or non-obstructive, you can find out by looking at the CSF flow in the scan. Now, whenever you see a CT scan of the brain, you have to first find the normal anatomy, try to localize where the lesion is. You have to describe the lesion, what type of lesion, whether it is a hyperdense lesion, whether it is a hypodense lesion, whether there is a isodense lesion with the brain parenchyma, and then you have to tell about the extent of the lesion. Then if there is a lesion, you have to see whether there is edema, some edema, vasogenic edema or cytotoxic edema, whether there is mass effect, whether there is midline shift, whether there is hydrocephalus. So all those things you have to mention about the lesion. And then you have to tell about the other bony structures, the fatty structures, and then the sinus and all those things. So there should be a total evaluation. You can start in the brain first, and then gradually, after looking at the brain, you can go in the skull, the fatty tissue, and also in the bone window, you can look at the sinuses and the other structures. So you'll have to go in a systematic manner so that you do not miss any obvious abnormalities. Sometimes the CT may be normal. Before commenting the CT is normal, you should systematically approach, look at the brain, the bone, the sinuses, and all the structures before saying that the CT scan is normal. Now I will just take you through the axial view of the brain from below upwards, and the key structures I will just let you know which are important in diagnosis of stroke. So this is the lowermost section here, and you can see this is the cerebellum. So these two structures are the cerebellum. These are the cerebellar hemispheres. The central part of the cerebellum is called as the vermis. Now this is the medulla. It's also called a medulla oblongata. So this is the medulla oblongata. It's a heart-shaped structure. So if you see this, there is the medulla oblongata. This is the CSF space here. And these are the maxillary sinus. And this is the lowermost part of the temporal bone, temporal lobe, which you can see here. Again, you go up a section cut higher, the temporal lobe is very well visualized here. This sinus is the sphenoidal sinus. Now, if you go higher up, after the medulla, you are having the pons. So this is the pons. This is the cerebellum, which I've already mentioned, right cerebellum, left cerebellum. This is the fourth ventricle. This structure, the round structure with, you can look at the darkness. As I already told, you look at this darkness. There it is, air is there, so it is the darkest. So after that, the darkest is CSF. So you can see there is CSF here. So this is the fourth ventricle. And there are connecting structures between the pons and the cerebellum. And similarly, there are connecting structures between the medulla and the cerebellum. Now, this is called as the inferior cerebellar peduncle, which connects the cerebellum to the medulla. This is the middle cerebellar peduncle. And when the midbrain is connected, it is called as superior cerebellar peduncle. So these are the three peduncles which you can see. And this is the temporal lobe. So I think I'm clear up to this. Next, higher section. So after the fourth ventricle, we are going a cut higher. So you can see the butterfly shaped structure here. So this is the midbrain. So midbrain is butterfly, medulla is very small heart shaped, and pons is like medium shaped and doesn't look like a butterfly. So if you see the butterfly structure, it is midbrain. Now this dot here is the aqueduct of Sylvius. So which connects the fourth ventricle below and the third ventricle, which is higher up. Here, this is called as the suprasellar cistern. So this is the suprasellar cistern. Here you are getting the temporal lobes in both the sides. Now you can see the lateral ventricle, the temporal horn of the lateral ventricle is visible now here. So this is the temporal horn of lateral ventricle. Why is it important to know the temporal horn? Is because this is the first structure which dilates whenever there is a hydrocephalus. So whenever there is an impending hydrocephalus, you have to look at the temporal horn of the lateral ventricle, which will be dilated. So that will say that there is an impending hydrocephalus. Now these are the sinuses. You look at here there is sinus. So it is very dark because air is there inside the sinus, we know that. So this is the ethmoidal sinus. It is as dark as the surrounding air outside. And this is the orbit. So this is the eye. You are having the orbital structure. Inside the orbit, again, there is fat. So you can see there again, it is dark. So air is dark, fat is dark, and here you are having CSF. So that is also dark, but less darker compared to that of the air and fat. Now going up. So this is just higher above that. So you can see this butterfly structure. This is the upper part of the midbrain. Again, it is visible here. Now this is the third ventricle. So aqueduct, here aqueduct gets ended, and then you are having the starting of the third ventricle here. You can see the part of the third ventricle here also. So these two structures are third ventricle. It is sort of a diamond shaped structure. So this is the third ventricle. Now this is the Sylvian fissure. So Sylvian fissure, below the Sylvian fissure is the temporal lobe. So this part is the temporal lobe. And now you can see the uppermost part of the cerebellum is seen, the vermis is seen. You can see the horizontal striation here. So that is the vermis. And then the occipital lobe has started to emerge here. So this is the occipital lobe. Okay. And this is the frontal lobe. And this is the third ventricle, which I have already mentioned. This area is called as the quadrigeminal cistern. Quadrigeminal cistern, that is posterior to the midbrain. Now just a cut higher to this. So this is the higher cut. You are having a lot of structures in this cut. So this is the lateral ventricle. This is the frontal horn of the lateral ventricle. And temporal horn I have already showed you here. This was the temporal horn of the lateral ventricle. And this is the frontal horn of the lateral ventricle. And here you are having the frontal lobe here. Now this bright structure, so this is bone. I have already told this is bone. Now this is again very bright. So this is calcification. So it is calcified pineal gland. So here you are having the pineal gland. So that is sometimes it gets calcified. So this is calcified pineal gland. So you can see the calcification is less dense than that of the bone, but it is more dense. I'll show you the bleeding. So when you will see intracerebral hemorrhage, you can see that is also bright, but this brightness is more than that of the intracerebral hemorrhage. Now, Once you go to the lateral ventricle, you can see this bulge here. So this bulge is called as the caudate nucleus. C, you can, this looks like an inverted C. So the bulge is the caudate nucleus. This is the basal ganglia structure. The entire thing is the basal ganglia. You are having the caudate nucleus. And then this part is there. You can see this triangular structure. So the medial part is globus pallidus and laterally you are having the putamen. So G and P, medially is globus pallidus, laterally is putamen. Now you look at this structure, L-shaped structure here, which is somewhat dark to that of the gray matter. I've already told you that gray matter is minus 35 to 40 Hounsfield and the white matter is less, bit darker because of the fat content and myelin and all. So this is around 20 to 25 Hounsfield. So this is the gray matter. This is the white matter. So this white matter tract is called as the internal capsule. So this L-shaped structure is the internal capsule. Now this is thalamus. This is again a gray matter. You can see it is brighter compared to this. So this is thalamus. And you are having the cortical gray matter here. All the frontal lobe, occipital lobe and all those things are gray matter only. And these are the deep gray matter. Deep gray matter constitutes of basal ganglia structures and the thalamus mainly. And peripheral gray matter is all the cortex, occipital, parietal, and all those things are the peripheral gray matter. So I am clear here. So caudate nucleus, globus pallidum, putamen. So this is called as the lentiform nucleus together. And you are having the internal capsule here and thalamus medially. And here you are having the third ventricle, pineal gland. And this is the part of the quadrigeminal system which is coming up. Now one cut higher, still the basal ganglia is visible. You can see the caudate, you can see the globus pallidum and putamen. You can see the dark internal capsule and the thalamus is here. And now in this cut, you can see there is a structure here like this. So this is the corpus callosum. So corpus callosum, we know that it is running from posteriorly to anteriorly like a fan. So when you cut it like this in an axial section, you can see there is a corpus callosum here. This is called as the splenium of the corpus callosum. And anterior part, the corpus callosum is going like this posteriorly to the anteriorly. So the anterior part is called as the genu of the corpus callosum here. So this splenium is seen here and the genu is seen here. And you can see here this is the choroid plexus. This is the lateral ventricle. And here you are having the choroid plexus. Inside the choroid plexus, from there only the CSF gets produced. And sometimes the choroid plexus may also be calcified. Two common structures which can be normally be calcified is pineal gland and choroid plexus. Okay, so this is again a labeled diagram of whatever I told. Here you can see in this CT scan, the choroid plexus is calcified as well as the pineal gland is calcified. So you can see this calcification is less compared to that of the bone. Okay, now we are going higher from the, still higher up, just above the internal capsule and then just above the pineal gland, and we are going higher up. So you can see this structure, this is again white matter. So internal capsule higher up, it is it goes up as a corona radiata. So this is called as the corona radiata. So this is the corona radiata. This is the superior sagittal sinus here. You can see this line-like structure. This is the superior sagittal sinus, and these are again part of the white matter tracts. Higher up, if you go higher up, then you can see this is called as centrum semiovale. So you are having the cortex like this. From there, the white matter tracts come in. The highest part is the centrum semiovale. Just below that is the corona radiata, and below that is the internal capsule. And from there downwards, it goes to the midbrain through the crus cerebri. It is called as the crus cerebri. So that is the descent of the white matter tract. So this is the centrum semiovale which you can see. Now this is the highest cut, almost near to the highest cut. Now this is very important because you can look at this structure here. So this structure is called as the central sulcus. So it is a very important landmark because once you find the central sulcus, the anterior to this is the frontal lobe and this is the parietal lobe. Posterior is the parietal lobe, and lower down, when you go down, you get the occipital lobe as well. So in the highest structure, in the highest level, you will get more of the frontal lobe and very less of the parietal lobe and no occipital lobe. And just anterior to the central lobe, central sulcus, you are having the motor strip, and posterior to this, you are having the sensory strip. So this is very important because if you get a very small infarct in this area, so this patient can present with isolated hand drop or wrist drop or a foot drop. So it can mimic a peripheral nerve palsy if there is an isolated lesion involving the motor strip. So this can mimic a mononeuropathy, like we get a radial nerve palsy, Saturday night palsy. The patient sleeps on the chair and then wakes with a wrist drop. So this can be a manifestation of stroke also if you are giving a very small lesion involving the motor strip in the area of the leg. Now in the motor strip, you know that there is something called as a motor homunculus. So motor homunculus means the leg areas and the bladder and all those fibers are medially, and then you get the face and the arms laterally. So if it's a very medial lesion involving the motor cortex, you can get a isolated foot drop. So these things, this knowledge of this anatomy can help us in localizing lesions and also diagnosing strokes. Okay, now we have finished the basic brain anatomy. So now I'll just tell you about the vascular anatomy, which is required in some cases of stroke. So this is the circle of Willis area. Now we know that the internal carotid artery is there. Internal carotid artery ascends upwards and then divides into two arteries. One is the middle cerebral artery and second is the anterior cerebral artery. And then you are having the posteriorly, you are having the vertebral artery, which join together to form the basilar artery, which ascends up and then divides into the posterior cerebral artery. So the posterior cerebral artery posteriorly and the middle cerebral artery and the anterior cerebral artery forms a structure which is called as the circle of Willis. So you look at this. So this is the middle cerebral artery here. This is the anterior cerebral artery. This one is the anterior cerebral artery. This is the ACOM, the anterior communicating artery. And then you are having this is the posterior cerebral artery. And this is the PCOM, so the posterior communicating artery here. Okay. And if you look at this, here we are having the basilar artery. So this is the basilar artery which goes and then which divides into the posterior cerebral artery. So this is the circle of Willis. So wherever you can get stenosis and all, you can see, you can find out. I'll show you examples later on in which you can find that there is some occlusion of the arteries. Now venous anatomy is also important in cases of venous strokes. So you know that there is this is a contrast scan. So you give this contrast and then the contrast gets goes into the arterial system and then later on into the venous system as well. So you can see the venous, this is the superior sagittal sinus. This is the straight sinus and this is the vein of Galen. And there are two lateral sinuses laterally. So all this form the venous channels. And if there is a block into the venous channels, which is called as cortical venous thrombosis, then you can get a stroke-like presentation also. So as I already told, CT scan, you have to look into the lesion and all those things I have already mentioned. And if it is a case of trauma, then definitely you have to be aware of all the various type of lesions which can occur. It can be extradural hematoma, it can be subdural hematoma, subarachnoid hemorrhage, intraparenchymal hemorrhage, and skull fractures, etc. may also occur. So before going into the trauma, just have a basic of the anatomy of the outer part of the brain and the skull. So this is the skull. Now below the skull is a very strong layer which is called as the dura mater, which is the outermost part of the brain. So dura mater is there. So dura mater has an outer and an inner part. This is the dura here. Below the dura is the arachnoid space. Okay. And then you are having the pia mater, which is directly which is touching the brain and in contact with the brain. In between is the subarachnoid space. So if you are having a subarachnoid hemorrhage, the hemorrhage will be below the dura mater and outside the pia mater in this space. So if you look at this, so this is the subarachnoid space. This is the dura mater, outer dura, inner dura, and this is the extradural or epidural hematoma. So epidural hematoma is outside the dura, is outside the inner layer of the dura and outside the arachnoid space. So this will follow the sutures of the brain because the dura is attached to the sutures of the skull. So because the dura is attached to the skull, so the extent of the epidural hematoma will be according to the attachment of the dura in the skull. So it will be a biconvex lens shaped type of structure. So if you look at this, this is the epidural or the extradural EDH, which we call, or epidural hematoma. So here it is outside the dura here. Now, if it is below the dura, it is called as subdural hematoma. So you can see there is the subdural hematoma. So this will be according to the shape of the dural attachments. So here you can see there is a subdural hematoma. And if it is in the subarachnoid space, we know that the subarachnoid space goes inside the brain in the fissures. So it will be going inside. So this is the subarachnoid bleed. And if it is injuring the brain parenchyma, then you can get the contusion of the brain, which can occur in the lobes of the brain. And also there may be diffuse microbleeds in the brain, which is called as diffuse axonal injury. So these are the various type of injuries which can occur. It can be outside the dura, where we call this epidural bleed. It can be subdural, it can be subarachnoid, or it can be diffuse axonal injury or contusions in the brain. Now subdural hematoma is very important, and we all know there are three types: acute subdural hematoma less than 3 days, usually hyperdense because blood is there, and then subacute subdural hematoma, which is isodense, and chronic subdural hematoma after 2 weeks, which becomes hypodense with an enhancing membrane as well. So you look at this. So this is the brain axial view. This is the bone. Okay. So you can see in the right side, there is a bright structure, bright lesion here. And it is totally bright throughout. So this is blood. So what is bright in the CT scan? As I already told, it is either blood or calcium. Now calcium you can see is very bright outside. So this is blood. And it is bright throughout. So this is an acute subdural hematoma. Now look at this. Here the brightness has gone down and it is almost just lightly brighter than that of the brain parenchyma. So this is subacute subdural hematoma. And after that, the blood products gets liquefied, and then it becomes more fluid. So then it becomes hypodense compared to that of the brain. So this is called as chronic subdural hematoma. So as the days pass, the brightness of the bleed starts to reduce and it becomes first brighter than the brain, then it is blood, then gradually it becomes isodense and then becomes hypodense when it's a chronic subdural hematoma. Sometimes there may be a mixed picture. It may be acute and chronic. Okay. So this mixture may also be there, especially when the patient is on antiplatelets and warfarin and coumarin and other novel anticoagulants. There may be different levels of bleed. So in the upper part, you may be getting blood may be, because of the gravity, the blood may be collecting in the lower part and the fluid may be going up, the liquefied blood. So then we call this it as a fluid level. So whenever there is a fluid level, that is suggestive that it is probably anticoagulant or some antiplatelet which is causing the issue and the picture in the CT. So that again you have to keep into mind. Now again in this patient you can see there is a right-sided, this is bright, right-sided structure lesion is there, extending, involving the frontal and the parietal lobes. And you can see it is bright throughout. So this is an acute SDH, and you can see what is this. This is the bone. You can see there is a defect here. So this patient underwent a burr hole surgery and the bleed has been evacuated. And you can see there is mass effect. How can you say the mass effect? This is the midline. So if you draw a line here, this is the midline. You can see the midline is shifted towards the right side. So there is the measurement can be taken with the cursor. Whenever the radiologist is reporting, they will measure it and tell how much midline shift is there. So you can see there is a midline shift here. And after the surgery, the midline shift has disappeared. The mass effect has disappeared because of the evacuation. Similarly, in this patient, there is a left-sided SDH is there. There is some acute part, some subacute part. And again, you can see there is a midline shift. So this will be the central line, but you can see the brain parenchyma here, the ventricle is being pushed to the opposite side. So here again, midline is shifted here. And you can see the lateral horn of the right temple lateral horn is also dilated. So that again says that there is developing hydrocephalus. So this is a definite indication for surgery in this patient. Again, you can look at this picture. You can see there is a collection here. Here there is a collection. Now here you can see that some part of the lesion is bright, some is iso-intense. So this is the brain. So it is iso-intense to the brain. Here again, this is bright and here it is somewhat iso-intense. And you can see this is the midline. So the ventricle is pushed to the opposite side. The temporal horn is dilated. So there is hydrocephalus and also midline shift to the opposite side. Again, there is midline shift to the opposite side. This structure is the pineal body. So the pineal body is also shifted. This is the calcification of the pineal body. So if you draw a line, you can find out how much midline shift is there. So this is again a definite indication for surgery. And there the subdural hematoma has to be evacuated. So here you can say it's a acute on subacute subdural hematoma, not very chronic also. So it's acute and subacute. So this again requires evacuation. So whenever you see a subdural hematoma, you have to look for this midline shift, mass effect, whether there is temporal horn dilatation or any hydrocephalus which is developing. You can see all of the ventricles have ballooned like this. The ventricles have become really round. So this is again suggestive of a hydrocephalus. These patients you have to pick up very rapidly, because once they deteriorate, then it is very difficult to resuscitate them. So you have to immediately, whenever you see the patient is deteriorating and then midline shift is there, immediately you have to send the neurosurgery opinion and get this bleeds evacuated. Now, sometimes detecting subdural hematoma may be very difficult, and we also have many problems, especially in the emergency setting. Patient comes with a acute hemiparesis and all, elderly patient. There may be no history of fall, and then when you examine, you may find there is some weakness of the opposite side. You do the CT scan and then it is reported as normal, and you see that the patient is in the window period. So you may plan to do a thrombolysis also for such patients. So before thrombolysis, always rule out a subdural hematoma, which may be very difficult. For example, in this patient, if you suddenly look at this CT, it may look as normal. But if you carefully look, there is a very iso-intense lesion here in this side. It is very iso-intense to the brain. So this is a subacute subdural hematoma, which is there, which is manifesting and causing the focal neurological deficit. Now, if you thrombolyze this patient, the patient is going to develop massive bleed, and then it may be a catastrophe. So you have to be very careful whenever you are planning for thrombolysis and rule out a subacute subdural hematoma, because it may be very difficult to find out. So you have to carefully look at the CT scan and maybe discuss with the radiologist also if there is a high index of suspicion. Now this is it a SDH or not? So you look at this. This is the CSF, and you can see that almost the intensity of the collection here is just bit brighter than that of the CSF, almost in the CSF intensity. So this is not a subdural hematoma. You can call it as a subdural hygroma. So whenever the fluid is very thin, so it can call it as a subdural hygroma. So this is a subdural hygroma. And you can see here there is the pineal body calcification also, which is seen. Now coming to subarachnoid hemorrhage. Subarachnoid hemorrhage is again a common situation. There are two important causes of subarachnoid hemorrhage. One is traumatic subarachnoid hemorrhage, and second is the aneurysmal subarachnoid hemorrhage. So if you look at this, this is the normal CT scan. These are the subarachnoid spaces. You can look at this CSF spaces here. Normally it is seen like this, but here you can see there is a bright blood which is spreading into the sylvian fissure and also the ambient cisterns and all the cisterns around the brainstem. And you can see the ventricle is also, lateral ventricle is dilated a bit. So there is mild hydrocephalus which is developing, and there is a diffuse bleed involving the basal cisterns and the sylvian fissure, etc. So this is a subarachnoid hemorrhage. So any hemorrhage which is spreading around the subarachnoid space is called as the subarachnoid hemorrhage. It may be traumatic or due to a aneurysmal rupture. Now here you can see in the CT scan, there is a bright intensity around the subarachnoid spaces around the right temporal lobe. So you can see this bright intensity. So these are all subarachnoid hemorrhages. You can see this is going into the sulcus. So these are all subarachnoid hemorrhage. So what should be the etiology of this patient? You can see there is a, I've already told, this is the skull, this is the fat. So in the fat tissue, that is the scalp fat, you can see there is a swelling here. So this is a contusion. So this is probably a traumatic subarachnoid hemorrhage which has occurred. Now coming to extradural hematoma. Now unlike subdural hematoma, extradural hematoma usually will be a biconvex shaped, and it will be outside the dura mater. So it will be biconvex shape, and you can see there is a biconvex structure here. There is a swelling of the temporalis muscle here, and there is midline shift also. So this is an extradural hematoma with mass effect. You can see this ventricle is dilated and this ventricle is chinked. So that means there is some pressure which is developing and pushing the brain to the opposite side. There is mild midline shift also. So in extradural hematoma, the neurosurgeons are having a very low threshold of surgery. So whenever you see extradural hematoma, definitely consult the neurosurgeon and ask for a surgical opinion, because there are fixed criteria which they follow, and they may go for a surgery, and it may be quite dangerous also. The extradural hematoma, sudden hydrocephalus may also develop. So again, you look at this, there is a biconvex lens shaped structure here involving the right temporoparietal area, and this is the midline, and you can see the midline shift here, and the opposite ventricle is dilated. So that means there is again mild hydrocephalus which is developing. So there is mass effect because of the extradural hematoma which has occurred. So this is again an indication for surgery. Okay, so trauma we have finished. Now we'll go to the spontaneous intracerebral hemorrhage. So this is again a very important condition, intracerebral bleed. So it is commonly seen. It is a very fatal disorder, and then this patient has to be managed properly to avoid fatalities which may occur. So what are the common sites of intracerebral hemorrhages? Now intracerebral hemorrhages, we know that which are due to hypertensive, which are also called mainly due to hypertension. So it is called as hypertensive bleed. What happens is that because of the chronic hypertension, there is vasculopathy in the blood vessel, and there is formation of something called as Charcot-Bouchard aneurysms. So this minor aneurysms, and because of the fluctuations in the blood pressure, these aneurysms rupture and give rise to something called as the hypertensive bleed. So how do we understand whether a bleeding is due to hypertension or due to some other etiology like a AV malformation or some other lesion? Now hypertensive bleed occur in around the deep perforating branches. So this will be at certain location. For example, basal ganglia, thalamus, the brainstem, pons, and the cerebellum. So these are the classical site of hypertensive bleed. So whenever you get areas of bleed in this area, then you're almost sure that this is likely to be due to hypertension. So you need not evaluate this patient further. So you need not do a CT angiogram or any other test to look for AV malformation or some other things if the bleed is in such site. So once again, so these are the classical site of the bleed. The basal ganglia, which I've already told, is the classical site of hypertensive bleed. The other site is brainstem, and then you are also having the cerebellum, which may be one common site of bleed, and thalamus. So there are four more common sites of hypertensive bleed. Now, sometimes the bleed may be lobar. Lobar means it is in one of the lobes, either in the parietal, frontal, occipital, or temporal lobe. So whenever you see a lobar bleed, then it is unlikely to be due to hypertensive bleed. So then you have to work this patient up to look for any other causes. What are the causes of lobar bleed? One is CAA. CAA is cerebral amyloid angiopathy. So what happens is that in the blood vessel, there is deposition of amyloid, and in the tissues, there is tau deposition, which weakens the blood vessel and gives rise to bleed. So this is called as amyloid angiopathy. So whenever you get a lobar hemorrhage in a non-hypertensive patient, then you think of it's likely to be amyloid angiopathy. Then tumor, sometimes a tumor may bleed. So that may again mimic like that of a stroke. Vascular malformation, AV malformations can bleed. So this again may be lobar. So lobar hemorrhage, your mind starts sticking, and then you think like there should be something else, and you investigate these patients, further with the angiogram, MRI scan with contrast to find out whether there is a underlying tumor, underlying AVM, or underlying amyloid angiopathy. So these are the classical site of bleed. So this is the basal ganglia bleed in the putamen. This is the thalamic bleed. Now you can look at this. This thalamic bleed has dissected into the ventricle, and you can see there is blood in the lateral ventricle also. There is mild hyperintensity also. So that means the ventricular, the thalamic bleed has dissected inside. Similarly, this bleed in the subcortical area has dissected inside the lateral ventricle, and it has gone to the opposite side also. There is some bleed here also. So one problem with the hypertensive bleed is that whenever they occur in such a force that they usually dissect inside the ventricles. And if they dissect inside the ventricle, the prognosis is bad, because sometimes they may develop hydrocephalus, ventriculitis, and all those things later on. So this is a brainstem bleed in the pons. This I told, this is cerebellum. So there is a cerebellar bleed, and this is a temporal lobe bleed. So this bleed you have to be careful, because it's unlikely to be hypertensive. Then you have to investigate. While other bleeds, you're fairly confident that it is likely to be a hypertensive bleed. Now the most dangerous of the bleed is the cerebellar bleed. So if you are having a cerebellar bleed, you have to be extra cautious. The patient has to be monitored perfectly, and then you have to maintain the GCS and evaluate this patient. The patient should be admitted in a stroke unit, because the cerebellum, you know that this is the brainstem, and you are having the fourth ventricle here, and this is the cerebellum. The space is very small. It is enclosed by skull. So once the bleed expands even by few ml, the pressure inside the system increases, and that will cause compression of the fourth ventricle, and which will give rise to sudden hydrocephalus, and the bleed may expand also very rapidly. So because of the smaller space and the CSF flow in such a way, the cerebellum becomes a very important issue, and then the patient may suddenly decompensate. So these patients, you have to be kept into vigil. And cerebellar bleed is again a very important indication for surgery. I'll tell you the criteria. So if there is a cerebellar bleed, you have to get the neurosurgery opinion initially itself, and then follow the patients up very carefully, and intervention has to be done if required in such patients. Now, how do we calculate the bleed volume? So this can be quite useful for assessing the patient. So bleed volume, if you are having a bleed like this, so this is the axial section, this is the coronal section. So coronal section will tell us the upper and the lower limit, and the axial section will tell us the anterior posterior limit. So if you look at the bleed volume, so you take the maximum diameters, that is in the anterior and posterior diameters A and B, and you take the vertical height of the lesion in the coronal section, so that is C. So if you do A into B into C divided by 2, so that will tell you the volume of the bleed. So this can be done intermittently, and you can see whether the volume of the bleed has increased. And again, initial volume of the bleed is again a prognostic indicator. If the bleed is very large, then definitely there will be bad prognosis. Again, for bleed in the lower areas, if the bleed is more than a specific volume, then again the chances of surgical intervention becomes also high. So knowing the volume of the bleed may be very important. Now, one important thing I would like to share is that how will you predict in an intracerebral hemorrhage whether the bleed is going to expand or not? Because the window period is very less. So suddenly you see in the first day patient gets admitted with a full GCS, there is a bleed which you have seen, and then suddenly in 24 hours patient suddenly the GCS falls, patient becomes comatose and ventilated. So how do we predict that this patient is going to be decompensate, or the bleed is going to expand? The most important thing is the blood pressure. So if the blood pressure is very high and not well controlled, then the chances of bleed expansion is high. So whenever there is an intracerebral bleed, you have to reduce the blood pressure and then try to maintain it around 140/90. Unlike infarct, in which we give the liberty of a high blood pressure in the initial few days, while in a bleed it is opposite. We have to reduce the blood pressure aggressively initially itself. So these are few signs which may be quite useful to make you alert that this patient is going to have a bleed hematoma expansions. In this patient, This is a bleed involving the right thalamus, and the bleed has gone into the ventricle. So you can see there is a curved line here. So again, you can see there's a curved line here. In this bleed in the left basal ganglia, you can see there is a vacuum sort of thing here also. So these are all bleeding blood vessels. So this is called as the swirl sign. So whenever you get a similar lines or hypointense areas in the bleed linearly, then you call it as a swirl sign. So this signifies that these are the bleeding blood vessels and there is more chances of potential worsening of the bleed. For example, in this patient, you look at this, there was a swirl sign here, and then this is the follow-up CT scan. You can see the bleed has expanded and the mass effect has also worsened. So if you see this scan and then if you can predict this, then definitely you can try to control the blood pressure properly and also get a neurosurgical opinion beforehand in case the bleed expands. So there is something called as an island sign. So this is the CT scan here, and you can see this is the main bleed here, and you can see there are a few isolated areas of bleed outside. You can look at this. So this is separated from the main bleed, and some areas it may communicate with the main bleed. So this is called as the island sign. So if there is island sign, again you have to be very careful because the bleed is likely to expand. Third is the black hole sign. It is like the swirl sign only. You can see there is some hypodense areas inside the bleed. Look at this areas here. So if you get such areas inside the bleed, again this is there. It's a bad prognostic marker, and it's likely that the bleed is going to expand. So this is called as the black hole sign. Now, in the CT scan, if you do a contrast CT scan of the brain, so this is the plain CT scan. You can look at, you can find the bleed in the left side around the thalamocapsular area, and this is the contrast scan. How do you find whether it's a contrast scan? You can see the blood vessels. So normal CT scan, usually the blood vessels are not seen. So if you can see the blood vessels properly, it is likely to be due to contrast which has been given. So in this patient, you can see here, this is the contrast scan, and you can see there is a dot here. So this is called as the spot sign. So dot means that is the leaking blood vessel. So this blood vessel is from where the blood has leaked out, and still it is patent, and it is likely that the blood vessel is going to leak again. So you can look at this patient, the bleed has expanded later on, and there is ventricular spread also. So the patient has worsened. So this spot sign may also tell us whether the patient is going to worsen or not. So black hole sign, swirl sign, spot sign, island sign. So these are the few signs which may help us to assess the prognosis and the hematoma expansion in such patients. Now this I've already mentioned, differential diagnosis of bleed. It could be hypertensive bleed, the 4 common sites I've mentioned. If it is lobar bleed, then you have to be extra cautious, whether it is a cerebral amyloid angiopathy, venous infarct, malformation, tumor, or something like that. And subarachnoid bleed most commonly is due to trauma and aneurysm. There is something called as a perimesencephalic non-aneurysmal bleed, which I'll be showing later on, and rare causes which can again cause subarachnoid bleed like dissection, posterior reversible encephalopathy, and all those things. I'll not go into the theoretical stuff now. So these are cases of lobar hemorrhage. So you can see the bleed is involving the right frontal area with ventricular extension. So this is cerebellar, this is amyloid angiopathy. Again, left, it's a left frontoparietal bleed. So again, it is amyloid angiopathy. Here there is an underlying tumor which has bled. So this is a tumor bleed. Sometimes there may be hemorrhagic metastasis. So especially tumors of the thyroid, follicular carcinoma, thyroid, renal cell carcinoma, all are known to cause hemorrhagic metastasis. So this may present with a bleed-like presentation. You can look at this. So you are having a hemorrhagic metastasis here. Sometimes there may be blockage of the venous channels, which I have already told, venous cortical venous thrombosis. So this can present with infarct with a bleed. So it's a hemorrhagic infarct. So that may again mimic a bleed. So if there is a lobar hemorrhage, you have to think of all these possibilities apart from a simple hypertensive bleed. Now, natural course of a bleed. So this is again very important. Sometimes the patient has a bleed, patient is treated outside and then comes to you for follow-up later on after a few months. So what will be the natural course of bleed? So you look at this patient, this is a bleed here. gradually the bleed density reduces and then it gets reabsorbed and forms a slit-like gliotic area here. Again, it forms a slit-like gliotic area. One more thing which you can see is that look at the ventricular size in this side. It is small and here it is enlarged. So that is due to gliosis. So when there is gliosis, there is tissue loss and there is traction and the ventricle gets enlarged to that side. So that means there is a gliosis in this side. So the issue is that if a patient comes with a stroke to you and then you are seeing the patient after 6 months, so it becomes very difficult to say, when you see the CT scan after 6 months, it will be like this. And if there is no proper documentation whether it was a bleed or infarct in the first attack, then it becomes very difficult to find out whether it was a bleed or infarct, because both will look like this. Even if it's an infarct, you will see gliosis. If it's a bleed, again you will see gliosis. The only way to make out is once you can look at the vascular territory, whether which territory it is. Infarct will be fitting into a vascular territory. Second thing is, in the MRI scan, you can there are some sequences for looking at old blood. So this is called as hemosiderin. So once blood goes inside the brain, it will be present there lifelong. So if you do certain sequences in the brain, like called as gradient echo or T2 star images, so with that you can find out there is old blood. So with that you can say that, okay, this patient had a bleed 6 months back and it was not an infarct. Because once you start the antiplatelet thinking that it was an infarct, if it was an old bleed, then there is a chance of recurrence of the bleed as well. So this again shows how the bleed resolves. So you are having a bleed and then gradually the bleed lyses. There is some edema here. So this is called as cytotoxic edema, and gradually the bleed subsides and you can see there is gliosis here. So after that it becomes very difficult to find whether it was a bleed or infarct in a CT scan. Okay, so we'll go to the anatomy of the arachnoid space. I've already told you this is the middle cerebral artery, this is the posterior communicating artery, this is the PCA, this is the basilar artery, this is the vertebral artery, and this is the anterior communicating artery, and then you are having two ACS like this. So the aneurysm can occur in any of this territory, and then that may give rise to a subarachnoid bleed. Now the location of the aneurysm can tell us, the bleed can tell us where the aneurysm is. Because if you get a bleed like this involving the basal cisterns, etc., so then either it's a aneurysm involving the PCOM or around the middle cerebral artery. If it is around anteriorly, then it is likely to be a ACOM aneurysm or anterior aneurysm. For example, if you look at this patient, you are seeing subarachnoid bleeds here all around. You can see the bleed here, hyperintense, hyperintense, hyperintense. And if you look at here, even the CT scan plane is showing an aneurysm around the anterior cerebral artery. So that means the location of the subarachnoid hemorrhage can tell us where the aneurysm is likely to be. If you look at this patient, you can see there is a basal bleed involving around the pons. So the basal area, you can see the blood here. This is the pons, this is the medulla, and this is the cerebellum posteriorly. This is a sagittal view which I have already showed. So you are having blood around this area. And when you do the angiogram, you can see there is a basilar artery aneurysm which has ruptured to give rise to the bleed. So the location of the bleed can tell us the regarding the location of the aneurysm. But if it's a massive bleed, then even a PCA aneurysm bleed also, it may spread upwards and involve whole of the brain. But in a moderate size subarachnoid hemorrhage, you can find out the location. So these are the various location of the bleed and the which you can see. If it's a basilar artery, it will be in the brainstem thalamus and the interpeduncular fossa. If it's a pica, then you will have the fourth ventricle. If it's an anterior cerebral artery, you will have in the sylvian fissure, and the MC also you will have the sylvian fissure in the temporal lobe. And if it's anterior communicating artery, you will get the bleed anteriorly around the septum pellucidum. Now, whenever you have a subarachnoid hemorrhage, three complications you have to be extremely careful. One is rebleeding. So once an aneurysm bleeds, there may be some sentinel bleed which may occur, and later on there may be a massive bleed again. So you have to be very careful about rebleeding. And second is there may be hydrocephalus which may develop later on. And third is the vasospasm, which we all know about, for which we give nimodipine and then prevent the vasospasm. So vasospasm usually occurs after the 7 days, and rebleeding usually occurs in the 48 hours. One more complication is syndrome of inappropriate secretion of ADH, which may again SIDH may also occur in as a complication of subarachnoid bleed. So all 4 complications you have to be careful, and then you have to monitor the patients properly. For vasospasm, there are new techniques like transcranial Doppler. So you can do the transcranial Doppler and look at the velocities of the MCA and the different arteries, and you can make out vasospasm early in an early stage. Now, one important situation, but rare situation, is perimesencephalic hemorrhage. Patient comes with severe headache and subarachnoid bleed-like presentation. You see there is some neck stiffness, and when you do the CT scan, you see a minor bleed around the pons and the brainstem area. You can look at this area. This is a sagittal view, and then you can see there is a small bleed here anterior to the pons. Here you can see the bleed anterior to the pons and the midbrain. Again, look at here. And you do the angiogram, it is normal. So this location of the bleed with a normal angiogram, it is called as a perimesencephalic hemorrhage. The importance is that this is not an arterial bleed, it's not an aneurysmal bleed, it's a venous bleed. Sometimes the veins get ruptured and give rise to the perimesencephalic hemorrhage. It has a good prognosis, and usually the patient recovers dramatically. So this is one differential diagnosis which you have to keep into mind. Now, AV malformation is a very important cause. You can see here there is a right parietal bleed, temporoparietal bleed with mass effect, midline shift. And when you do the CT contrast, you can see there are some abnormal blood vessels here. You see the abnormal blood vessels which are communicating. So whenever you get abnormal dilated veins and abnormal communications along the bleed, then you have to think that it is likely to be a AV malformation. So this patient had AV malformation. Similarly, you look, there's a bleed here in the right frontal area, and you can see there is abnormal venous communications here. So this is again a AV malformation. So this to detect AV malformation, you have to do a CT angiogram with contrast to find out the abnormal venous communications. Again, there is a bleed here, and you can see there is a abnormal dilated communicating, and this is called as the nidus of the lesion, and then there are dilated communicating veins. So all those things tell us that there is an abnormal AV malformation. So AV malformation can be of various type. I'll not go into the details. It can be AV fistula, dural AV fistulas, vein of Galen malformations, etc. So all various types are there, and sometimes you may need something called as a digital subtraction angiography, because the AV malformation, AV fistula and all, you have to do procedures to occlude them. You may do coiling and all those things. So in that case, you have to do a digital subtraction angiography to delineate full of the fistulas so that you can evaluate. So here you can see there are abnormal blood vessels in this area around the bleed. So that was a case of AV malformation. Okay, so we have finished trauma, we have finished the bleeds, the hypertensive bleed, the subarachnoid bleed, the lobar bleed. Now we'll go to the ischemic stroke, so which is the last part. I'll quickly go through this. We all know that ischemic stroke is the most common type of stroke, and ischemic stroke can be large vessel stroke involving the larger blood vessels. It can be lacunar strokes in which it involves the deep penetrating branches. It could be cardioembolic stroke in which there is embolus arising from the heart which goes into the brain, or it may be due to some vasculitis, polycythemia, and all sort of other things. So for knowing the strokes, ischemic stroke, you have to know the blood supply of the brain. So basically, this is the territory of the anterior cerebral artery. The MCS supplies majority of the temporal and the parietal areas, and PCS supplies the occipital areas and also the brainstem. So the midbrain, the cerebellum, the brainstem, all are supplied by the posterior cerebellar arteries. So these three territories you have to know. In between this, you call as the watershed zone. For example, this is the HCA territory. This is the MCA territory. So you are having the ACA MCA watershed zone. This is the PCS territory, that is the occipital lobe and the brainstem and other structures. And this is the PCA MCA watershed. So these are the outer or external watershed. zones. Now, if you look at the CT scan, you can see there is a hypodense lesion. Why we call it hypodense? This is the brain parenchyma. So this is the normal brain parenchyma. You can see it is darker than that of the brain parenchyma. So you see there is a hypodense lesion, wedge shaped, involving the right temporal and part of the frontal area. So this is a infarct. So hypodense area involving the side. I will tell you how to differentiate a chronic, subacute and acute infarct later on. This is again this is the normal brain parenchyma. You see there is a hypodense lesion here involving the right occipital area. So this is a posterior communicating artery infarct or posterior circulation stroke involving the right occipital area. Now the pathophysiology of infarct, you all know, when the cerebral blood flow reduces less than 18 to 20 ml of cerebral blood flow per 100 gram, then you get there is reduction in the metabolic activity, failure of the sodium potassium pump. As a result, there is cytotoxic edema and then cell death, which gives rise to the infarction. So 18 to 20 is the limit in which there is ischemia to the tissues, and less than 10 you'll get infarction. So from 18 to 20 it is called as the borderline zone or the penumbra, in which the cells are involved but it has not been damaged completely. But less than 10 you get the infarction or death of the neurons. So this concept you have to know, it's called as the penumbra. So there is a infarct core inside in which there are dead cells because the blood flow is less than 10, and in the area where it is around maybe around 12 to 20, so you'll get the penumbra. So penumbra means the cells are involved, they are stunned, but they are not irreversibly damaged. So if you treat this stroke, then the penumbra area you can salvage. Now, what are the goals of stroke imaging? So whenever you look at stroke, there are 4 P's of the stroke imaging. One is parenchyma. So parenchyma means how is the brain. Second is the pipes. So what does the pipe means? Pipe means from the heart to the brain, the blood vessels which are communicating from the heart to the brain or carrying the blood are called as the pipe. So it means the aorta, the arteries, the common carotid, the internal carotid arteries, the MCA, the PCA, the ACA, all these are the pipes which take the circulation. So whether there is any block there. Third is the perfusion. So what is the blood supply of the brain? And fourth is the penumbra. Penumbra means what is the size of the stroke, exact size, and what is the area which has been functionally affected but which are still, the neurons are still alive. So that is the penumbra. So these 4 P's you have to define whenever you are having a stroke. So I'll go later on. So what is the role of CT brain in stroke? Ischemic stroke. So CT brain, there are 3 types of CT brain which are used in ischemic stroke. One is a non-contrast CT or a plain CT. Second is CT angiography, and third is perfusion CT. These 2 are not much required for us. Plain CT is the most important, but you should know what is the use of CT angiography and perfusion CT, because in the days to come, with the advent of thrombolysis and mechanical thrombectomy and various procedures for treatment of ischemic stroke, CT angiography and CT perfusion scan will be day-to-day practice in the few years to come. So CT scan, what is the most important goal is to detect hemorrhage, to detect early signs of infarction, to quantify the stroke area and exclude other neurological causes. Now, whenever there is an acute or hyperacute stroke, less than 12 hours, the CT scan may be normal. So then a very important sign which you can find is called as the hyperdense MCA sign. So you look at, this is the middle cerebral artery here. There is a middle cerebral artery here also. So you can see there is a very bright signal in the middle cerebral artery. So this means the middle cerebral artery on the right side is completely filled by a thrombus. So it is totally occluded. So this occluded middle cerebral artery is called as a dense MCA sign. So when you do the CT scan, patient comes with stroke, patient is having aphasia and right-sided hemiparesis, and you do the CT scan, you see that CT is normal, but you see that the blood vessel on that side, the MCA artery on that side is showing a bright signal like this. So that is a very serious symptom, and it means that the entire blood, the MCA artery has been occluded, and within few hours the whole area of the MCA supply is going to be damaged, even though the initial CT appears to be normal. So this is a very important sign which should not be missed. What is the importance is that if you're having a very dense MCA sign, that means the whole of the blood vessel is blocked. So you have to open this blood vessel. So this blood vessel can be opened by two ways. One is by doing a intravenous thrombolysis. Now, if you do an intravenous thrombolysis in a patient in which the MCA is totally occluded, the chances of opening the blood vessel is around 20 to 30%. So 70% of the time the thrombolysis will fail. So in such patient, if you see this sign, if you are having a cath lab with mechanical thrombectomy facilities, immediately you can take the patient to the cath lab and remove the clot by doing a mechanical thrombectomy through various devices. So that is one thing which this sign will tell us. Again, there is something called as a MCA dot sign. So MCA dot sign means more periphery, not the stem of the MCA, but the as we all know, MCA has many branches. One is the stem, then you are having M2, M3, M4, and then the distal branches. So if the distal branches are blocked, then you get the MCA dot sign. So you can see there is the MCA dot sign. This side, there is nothing like that. So that means there is a thrombus here. So this again tells that the MCA artery is occluded, but not in the stem, but distally. So the deficit will not be as severe as in the stem of the MCA artery. Now there is one important sign which is called as the blurred basal ganglia sign. So if you look at this side, you can see there is the sulcus which is visible. But here you can see this part of the brain is swollen. So there is no differentiation in the gray and white. Here you can see properly, but here all looks the same. You cannot find the sulci and all those things, and there is no differentiation of the gray and white matter. So this is the earliest sign of a infarction also in this, the basal ganglia region. This is called as the blurred basal ganglia sign. So unless you are trained in looking at acute CTs, this scan may be missed and interpreted as a normal scan. Similarly, there is something called as an insular ribbon sign. So look at this patient here. This is the normal brain here. You can see the sulci here. This is the white matter. This is the gray matter. So differentiation is maintained here. But you look at this, the sulcus are not seen. The entire area appears to be swollen. So this area is called as the insula. Outside the internal capsule, you are having the external capsule and then the insula. So the entire insula is swollen. This is called as the insular ribbon sign. This is again an early sign of ischemic stroke. So this again you have to pick up if it is there. Now after the subacute, after the initial period, then comes the subacute stroke. So after almost 1 to 3 days, you look at this, there is a hypodense area here. And you can see this wedge-shaped area here. So there is a definite ischemic stroke because there is hypodensity. The brain is appearing dark compared to that of the gray matter and the white matter. So there is a ischemic stroke. Here the territory will be a right MCA territory in this figure, and here there will be a left MCA territory. Now it becomes very easy. Anybody can find out there is a stroke here. But what is the point? The point is in preventing this stroke by early detection of the stroke. When you get the insular sign or the basal ganglia sign or the dense MCA sign, at that point, if you intervene, you can prevent the formation of the stroke because already this part of the brain is dead. So early intervention is the key. And if you look at this, you can see there is a hyperdense blood vessel here. So this is the MCA artery. So this artery is occluded, which gives rise to this stroke in this territory. So this is again a sign of a thrombosed blood vessel. Now, after the acute phase, in the subacute phase, this is an infarct involving the left occipital area. So this is a posterior cerebral artery stroke involving the left occipital area. The thalamus is also involved. So subacute strokes are very easy to pick up. Now, what happens in the chronic stroke? How will you differentiate acute stroke and chronic stroke? Now, acute stroke, you see, this is the infarct. You are having mass effect. The ventricle in that part is pushed away and there is mass effect. While in subacute stroke, in chronic stroke, there will be no mass effect and the ventricle will be pulled towards that same side because of the formation of the gliosis. So lack of mass effect and pulling the ventricle to that side tells us that this is a chronic infarct. And one more thing in chronic infarct is the intensity will be very dark. So look at this. If you look at this, it is this is mildly dark. This is again not very dark. This is somewhat more chronic. It is more darker. And this is the darkest because it is the most chronic one. So the darkness, more darker the lesion, the more chronic the infarct. Similarly, you can see a very dark lesion here. So this is again an old infarct. Now, lacunar infarcts means smaller infarcts which occurs in the penetrating branches. So you can see there is a small infarct involving the basal ganglia. So this is a lacunar infarct. So if you get such infarcts, it is in the penetrating branches. But if you get a larger infarct, you think that it is due to the occlusion of the larger blood vessels like ICA, MCA, or it may be due to some cardioembolic source from outside. Okay, so one important scoring is I like to tell you is that is called as the aspect score, which is used in stroke, in which you can grade as various area, M1, M2, M3, and all those areas are there, and then you create a score. So the lower the score, larger will be the infarct size. So this will tell us regarding the thrombolysis. So in thrombolysis patient, you can tell the aspect score, which will tell us how large the infarct is. So this is one score which you can remember. So this is the aspect score. You can 9 areas, 10 areas are there which you have to quantify and then score. I'll not go into the details. So what is the advantage of CT scan? The advantage is that it is very quick. It is widely available. Every hospital has a CT scan. Cost is less and it can be done very quickly, especially in an uncooperative patient, critically ill patient. MRI becomes very difficult. So it can be quickly done. And also wherever there is contraindication of MRI, CT scan can be done. And most importantly, the most advantage of MRI CT scan is it can help us exclude bleed. So if there is an intracerebral hemorrhage, if you are suspecting hemorrhage, the investigation of choice is CT scan. It's not MRI scan. So with a CT scan, you can rule out bleed. So it becomes very useful in thrombolizing patient. So whenever a patient comes with a stroke-like symptom, you don't know whether it's an infarct or a bleed. So you do the CT scan. If the CT is normal, then you are sure that it is not a bleed. It is likely to be an infarct. If it's the early CT scan, the infarct may not be visible. So limitation is that sensitivity is less. Then there are inter-observer variations. You cannot differentiate the penumbra and the infarct core and all those things. In which case MRI becomes and has a lot of advantages. So perfusion CT, I'll not go into the detail. So perfusion CT, you have to know that it tells about the blood supply of the brain. So if you are having a stroke, what part of the stroke is dead and what area of the brain is at danger will be told, will be explained by the perfusion scan. So you can do a CT perfusion scan to find out the what part of the area of the brain can be saved. It is especially useful whenever you are doing intervention for the treatment of acute stroke. So if you're planning to do a mechanical thrombectomy, perfusion scan is required to find out what how much of the stroke is salvageable. So these are various principles of perfusion CT. I'll not go into the details because we don't have time. So you look at this. So if you get a colorful image like this, so this is the perfusion scan. So here you can see this is the area of this stroke in which the tissue is dead, but the total area at risk is very large. But the actual dead area is very small. So that means this much area you can save after doing the intervention or opening of the blood vessels. So this idea will be given by the perfusion scan, so which is much used in all centers who are doing intervention for stroke. Okay, I'll not go through this. Now, one more word about CT angiography. So why should we do CT angiography? CT angiography we do from the arch to the vertex. So it's called as arch to vertex. So you start from the aortic arch up to the vertex. So CT angiography is important because in a stroke, CT angiography will tell whether there is an aortic dissection, which may again present with stroke, whether there is ICA dissection, which may present with stroke. It can tell us whether there is a blockage or occlusion of the internal cerebral artery or middle cerebral artery. So all the major occlusions, thrombosis, whether there is some unstable plaque, all this can be explained by a CT angiography. So it is also ideal to do a CT angiography in every patient presenting with suspected ischemic stroke. For example, if you look at this patient has presented with aphasia and right-sided hemiparesis. Now, this is the dense MCA sign here. Here the MCA is not seen, but you can see there is a thrombus in the MCA. Now, if you do a CT angiography, you can see that the right-sided MCA arteries are very well visualized, but you can see there is a cutoff in the left side. Again, you see here, right side is very well seen, but left side is not seen. So with the angiography, you can exactly pinpoint which area of the artery is occluded, and you can plan the treatment of the patient. So this is the advantage. And okay, so finally I will summarize. In thrombolysis, what is the role of CT brain plane? So the plain CT scan brain, first is to rule out bleed, because if there is a bleed, you cannot thrombolize the patient. Second is to find out evolved large infarct. So if your patient comes with stroke, you do the CT scan, already there is a very large infarct evolved. So you will not thrombolize this patient. And you want to detect the early signs of infarction and also to do the aspect score. So that is the main aim of CT brain. CT angiogram to look up for the mechanism of the stroke, what blood vessel is involved, whether there is any dissection or not, because if there is a dissection, that is a contraindication for thrombolysis. So that again you can find with a CT angiogram. CT perfusion is for delayed thrombolysis and also for mechanical thrombectomy, which can be done up to 24 hours. So now the stroke window has increased. Initially we think we should thrombolize up to 3 hours, then it increased to 4.5 hours. Now people say that up to 9 hours you can thrombolize if there is a penumbra in the CT perfusion. And mechanical thrombectomy you can do up to 24 hours if you can demonstrate that there is a definite salvageable brain or a penumbra around the infarct core. So that is the importance of CT perfusion to guide us regarding the management of acute strokes. So this is the protocol which is being followed in standard hospitals. CT scan they will do if there is a hemorrhage, stop, no further investigation. If there is a infarction, then they will do a CT perfusion, CT angiogram, and then evaluate the patient and do either thrombolysis or mechanical thrombectomy. Now, last thing, when will you refer for neurosurgery? All critical care emergency physicians, if you are getting a cerebellar stroke, so you can see here, this is the right cerebellum, this is the left cerebellum. So there is a large cerebellar stroke here, and which is pressing onto the brainstem, and there is hydrocephalus also. The fourth ventricle is also compressed. So if you get a cerebellar stroke like this, this is an urgent neurosurgical intervention. You have to send this patient to neurosurgery. Similarly, you get see the cerebellar stroke here, and there is a lot of hydrocephalus. So this patient again requires surgery, again surgical intervention. So any cerebellar infarction, you have to be very careful. Second, look at this. There is a cerebellar infarction, and what the neurosurgeon will do, they will remove the skull from the posterior part. So this is called as suboccipital decompression. And also they will put a ventricular peritoneal shunt to reduce the pressure of the hydrocephalus. So with a suboccipital decompression and a VP shunt, the cerebellar infarct patients, we can help them survive in the acute phase. Now, MCA infarct. This is a malignant MCA infarct involving the right MCA territory. You can look, there is a hypodense lesion here involving the right MCA. There is midline shift. The ventricles are dilated. The brain is shifted to the opposite side. This patient, if you leave, this patient is going to die. So to make the patient survive, what you can do is you can remove the skull of this side. The skull has been removed here. The skull has been removed here. So this is called as a decompressive hemicraniectomy. So if you remove the skull in this side, the brain will expand, and gradually once the pressure comes down, the brain will come back to its normal form. So this is a life-saving procedure which can be done in malignant MCA infarcts. Cerebellar bleed, again very important. You have to ask for neurosurgery consultation, and also intraventricular hemorrhages. So any hemorrhage which has gone into the ventricle with hydrocephalus may also require neurosurgical intervention. So these are the criteria: cerebellar hemorrhage more than 3 centimeter with hydrocephalus and all those things. You have to definitely send for neurosurgery and evaluation. And lobar hemorrhages which are more than 30 cc and within 1 centimeter of the surface, again may require surgical evacuation. So you look at this, there is a right frontal hemorrhage with lot of mass effect. The ventricle is shifted to the opposite side. There is midline shift. So this patient will require surgical intervention. So lobar hemorrhages very close to the surface, more than 30 cc, definitely you can send for craniotomy and evacuation of the bleed. So that is all from my end. Thank you for the patient listening.
Thank you, sir. Today you have outdone yourself. A breathtaking presentation, absolutely mesmerizing. So we have got many questions. Now I'm starting from Dr. Meisam Sobahan. Meisamer নিজের 4টা কোশ্চেন আছে, আমি স্যার একটা একটা করে করছি। Sir, first question: how can we identify ischemia in first 6 hours in CT brain?
Yeah, first CT 6 hours, as I already told, the CT brain may be normal as well, but certain signs like the dense basal ganglia sign, the insular ribbon sign, all this can help us. All the dense MCA sign, this can be early marker of the ischemia. So this may help us in identifying early stroke.
Next question, sir. What is the indication of CT angiogram, MRA in stroke or headache patients?
See, CT angiogram and MRI, that depends upon the availability. Both are equally good. The importance is that MR angiogram is a non-invasive. You need not give the contrast. You can do TOF images also, which are without contrast. Now, both are efficacy-wise, both are same, but the indications are in acute stroke. As I already told, CT angiogram is required to find out whether there is any dissection, to find out how the patency of the blood vessels are, whether there is any thrombosis, whether any blood vessel is occluded, large blood vessels are occluded or not, whether there is a unstable plaque inside the blood vessel. So all these things can be found out by a angiogram. Now in a headache patient, angiogram is required if you are suspecting a subarachnoid hemorrhage. So if there's a subarachnoid hemorrhage, you have to do an angiogram to find out aneurysm. Now, if you are suspecting a venous thrombosis, if there is a venous thrombosis, then you have to do the venogram, CT venogram or MR venogram to find out thrombosis. There are certain conditions called as reversible cerebral vasoconstriction syndrome, in which you may have thunderclap headache, recurrent thunderclap headache, vomiting, and all those things. Again, the angiogram will show the string of bead appearance, and which will be reversible after some time, after 12 weeks. So that again may be quite helpful. So in those conditions, you can do angiogram. And whenever you are suspecting vasculitis, so if the headache is due to, you are suspecting the stroke and headache is due to vasculitis, angiogram may again be quite useful.
Sir, his next question, though you touched it and you answered it already, till then, sir, how can we differentiate between old hemorrhagic from old ischemic stroke?
It becomes very difficult. So I've been really puzzled seeing old scans when the patient doesn't have a document whether it is CT or old stroke was a bleed, or in fact it becomes very difficult. The one thing which you can look is the vascular territory of the infarction. So if it's an infarct, it will be in a particular vascular territory, either the MCA territory or in a particular territory, and the shape of the lesion also. So with that you can find out, but ideally I'd suggest that you can do a MRI. So with that you can find out the hemosiderin deposition, which can definitely tell you whether it's an infarct or a bleed.
Sir, his last question. Sir, success of thrombolysis in your settings or in your country?
Yes, thrombolysis is quite useful. And issue is now the trend is changing because I practice in a suburban setting. So what I do routinely is thrombolysis. So because that is what is available, we don't have a cath lab with mechanical thrombectomy, but in the trend is now changing towards mechanical thrombectomy. That means initial 4.5 hours, if the patient is coming to the hospital, and if you are having a good CT scan and a proper patient without much deficits, then you can thrombolyze the patient. But if you think that the deficits are too much, the NIHS score is very high, and if you are having a facility of a cath lab, then definitely mechanical thrombectomy is the key thing now. But you have to carefully select.
Thank you, sir.
Carefully select the patients for thrombolysis, because the bleed of intracerebral hemorrhage, I think most of us are aware, it is around 6%. So if you wrongly select patient in the later of the window period, then the chances of bleed becomes very high.
And sir, a very important question from most of the participants, I think. Sir, MRI or CT scan, which one is gold standard for TIA?
See, I think the concept has to be made clear. TIA means transient ischemic attack. So transient ischemic attack means the patient has a neurological deficit which lasts for almost 10 minutes to 60 minutes. So that is the commonest period of transient ischemic attack. usually the CT scan will be normal in a TIA. So TIA means normal CT scan. Now, whatever TIA which we used to say in the era of CT scan, now with the advent of MRI, in many of the such patients, we can find very small infarcts in the diffusion weighted image. But if you find a infarct in a MRI in the diffusion sequence, it is no longer a TIA. So TIA means both the CT and MRI should be normal. But in the days in which there was no MRI, we used to find a normal CT and we used to say TIA. But now with the advent of MRI, we find that most of these TIAs are actually minor strokes. So both should be normal.
Thank you, sir. Sir, next question from Dr. Musanna. Sir, how to differentiate between subarachnoid hemorrhage with AVM? In both cases, vessel looks prominent.
For that, you have to do a CT angiogram. So CT angiogram, what you will find is if it's a AV malformation, there are various types of AV malformation. In CT angiogram, you can definitely find draining veins or draining blood vessels and the nidus of the lesion. So which will not be seen in a subarachnoid hemorrhage. And in the subarachnoid, you will find aneurysms. While in angiogram, you will find the nidus of the lesion. So you have to do a CT angiogram in such cases to differentiate. With plain CT, it may be very difficult.
Then next one from Dr. Muhammad Omar Ali. Sir, thanks, sir, for your vivid and lucid presentation. Absolutely correct. Can you kindly give some explanation regarding the following? Number one, MCA dot sign versus MCA calcification. Number two, hydrocephalus versus ventricular enlargement due to gliosis.
See, MCA dot sign is due to a thrombus which occurs in the MCA in the distal portion, that is around the M2, M3 division. So the intensity of the thrombus will be a bit lighter compared to that of the MCA calcification. If it's MCA calcification, the Hounsfield unit will be higher, while if it's a thrombus, it will be lesser in size. The shape of the calcification may be irregular, while thrombus may be somewhat linear around the blood vessel. So with these things, you can differentiate, and then definitely you can do the angiogram if you are having any confusion, because that will show the MCA cutoff distal to the thrombus. Now, hydrocephalus and ventricular enlargement due to gliosis. Hydrocephalus is due to the CSF pressure. So if there is an active hydrocephalus, you will get periventricular seepage. So if you are getting periventricular seepage around the hydrocephalus, that means it is a hydrocephalus. While ventricular enlargement due to gliosis, it will be a pulled asymmetrically dilated ventricle. So it will be asymmetric, it will be, ventricle will be pulled, and the margins may not be so rounded off, and there will be no periventricular oozing. So that with that, you can find out whether it's a hydrocephalus or a gliosis.
Thank you, sir. Dr. Mahmudul Hassan, will you ask any question live?
Yes, sir. Assalamu alaikum, sir.
Okay, please.
At first, I would like to thank sir for his excellent, wonderful presentation. Sir has explained and described almost everything. I have two questions to sir. My question is, as the hemorrhagic changes or ischemic changes take some time to develop, so is there any time frame or ideal time to do CT scan of brain, or we can do it immediately when we suspect stroke clinically? My first question is this, and my next question is, in our limited resource setting, sometimes it is difficult to do CT scan, especially in Upazila or that level. So in such cases, should we use steroid or any other drug like manisol in different cases before seeing the CT scan? And my last question is, when we should use contrast, and before using contrast, what clinical information or investigation should we do minimally before giving contrast? Thank you, sir. Thank you for
Okay. Yeah. So I think first question he asked was, when should the CT scan be done? So yeah, CT scan, see, the problem with CT scan is that first 24 hours, the CT scan may miss infarcts. But the issue is with the advent of thrombolysis. So if the patient is coming acutely to you within the window period, then immediately you have to do the CT scan. You cannot wait till the time that the CT becomes positive. And the ideal period is whenever you see the patient, if it is within the window period, you have to do immediately. Otherwise, after 24 hours, you can do the CT scan to detect the stroke. Now, second question, what he asked was role of steroid. Usually, steroid we do not use in stroke. Steroid is only indicated in case of vasogenic edema. So whenever there is a vasogenic edema due to tumor or some mass lesion, then you can use steroid. For cytotoxic edema, which we see in stroke, usually there is no role of steroid. Now, one thing is clinically, it becomes very difficult to find whether it's an infarct or whether it's a bleed. But if there is severe headache, and then if you're getting pinpoint pupil, severe headache, vomiting, seizures along with the onset of the stroke, then the probability of having a bleed is more than that of an infarct. Giving mannitol empirically is not suggested, but if you are seeing that okay, the time duration to get the CT scan is very long, then definitely you can give mannitol if you see signs of raised ICP in the patient. So very low GCS. Then if you are seeing dilated pupils or some decerebrate, decorticate posturing and all, then definitely you can give a dose of mannitol just before the CT scan of the brain. Did I miss any
last
question?
two questions.
Yeah.
About contrast.
Okay, sir. Last
Contrast. Okay, contrast CT scan is not required in all the strokes. Contrast CT scan, before doing the contrast, you have to get the renal function seen, because if there is a renal function, there can be issues. Kidney failure, there can be issues. Second is if the patient is on metformin or similar drugs, the contrast may cause issues. And if there is a multiple myeloma and all those things, again contrast give rise to nephropathy. So all those things you have to be careful. An indication for contrast is regular intracerebral hemorrhages. Contrast is not required. But if you are having a lobar intracerebral hemorrhage, then you have to do a contrast. If you are doing a angiography for subarachnoid bleed to look for aneurysm, then you have to do CT angiogram with contrast. And if you are suspecting tumors or venous thrombosis and other things, contrast is required. Simple brain stroke, that is ischemic stroke, or clear-cut hemorrhagic hypertensive bleed, contrast is not required. Otherwise, if there is a high index of suspicion, you have to do give a contrast.
Sir, the patient who has previous history, sir, is serum creatinine is enough to look for before giving contrast?
Yeah, that is enough.
Thank you, sir.
Yeah.
Thank you. So last two questions. Sir, from Mohammad Rejaul Karim, sir, it's a bit practical questions. যেহেতু আমাদের দেশে তো স্যার আপনি জানেনই অনেক পেরিফেরিতে আমরা অনেক ডক্টররা কাজ করে যেখানে ইমেজিং ফ্যাসিলিটিস নাই। এই কোশ্চেনটা হচ্ছে স্যার, থ্যাঙ্কস ফর দিস এক্সিলেন্ট প্রেজেন্টেশন, নো ডাউট ইট ওয়াজ এক্সিলেন্ট। স্যার, আই এম কিউরিয়াস টু নো ইফ উই ডোন্ট হ্যাভ এনি ইমেজিং ফ্যাসিলিটি and BP is more than 180 over 110, how should we approach to manage BP in stroke patient with no other organ failure?
See, the BP management in stroke differs. So first you have to know whether it's a ischemic stroke or a hemorrhagic stroke. So unless you know whether it's a ischemic stroke or hemorrhagic stroke, the target you cannot decide. So if it's a hemorrhagic stroke, the guideline is there are a lot of studies, Intract 1, Intract 2 and all those things. So the message is that you have to reduce the blood pressure and keep around 140/90 or up to 150/90. You should not reduce it very much, and it should not be high also. It should be around 140 to 150, and lower it should be 90 to 100. So that should be the target in case of a hypertensive bleed or any sort of bleed. Now if it's an infarct, the blood pressure initially in the first 3 days you can reduce only if it is more than 220/110. So if it is more than 220 to 110, systolic 220 and diastolic 110, then you can reduce the blood pressure. Or if you are planning to thrombolyze the patient, so if you are thrombolizing the patient, then you have to reduce the blood pressure to 180 to systolic and 110 diastolic. Otherwise you can give a liberal blood pressure for the initial 3 days, and after that you can gradually reduce the blood pressure maybe by 20% onwards. So ischemic stroke, do not reduce the blood pressure rapidly unless you are planning thrombolysis, And hemorrhagic stroke, you have to reduce the blood pressure and keep it around 141 to 150 systolic and around 90 to 100 diastolic. So that should be the message.
Thank you, sir. Last question, though there are many questions, but I'm taking this one last. It's from Dr. Juthi Dash. Sir, please tell me again about gliosis and how to differentiate it from ischemic stroke.
Gliosis from ischemic stroke. Okay.
Yes, sir.
See, the gliosis can occur in any etiology that you have to be aware of. It can, if there is an infarction, then there will be a gliosis. If there is a hemorrhage which resolves, then there will be a gliosis. If there is a trauma which resolves, there will be a gliosis. So everything will give rise to gliosis. Now, ischemic stroke, it will depend upon the stage. Now, if it's an acute ischemic stroke, then the intensity of the lesion will be very light. It will be not very dark. It will be just lighter than that of the brain parenchyma, and there will be mass effect. So there will be some mass effect. The ventricles will be effaced. The gray-white differentiation will be lost. In the subacute stage, the lesion will become more darker. The gray-white differentiation will be there, and the mass effect will reduce. And in the chronic phase, you get the gliosis. The ventricles will be pulled, and then the lesion becomes very dark. So these are the stages of the infarct. So depending on the stage of the infarct, you can differentiate from the gliosis.
স্যার আরো অনেক কোশ্চেন আসলে আছে, আমি আর কোশ্চেন নিচ্ছি না। স্যার আমাদের মাঝে আছেন বাংলাদেশের একজন খ্যাতনামা ইন্টার্নিস্ট প্রফেসর ডক্টর মোহাম্মদ ইসমাইল পাটোয়ারি। পাটোয়ারি স্যার, আপনি কিছু বলবেন? পাটোয়ারি স্যার হয়তো এই মুহূর্তে স্যারের কানেকশনে আছে। স্যার আসলে আমি যেটা চাচ্ছিলাম যে আসলে আমার কেন জানি মনে হচ্ছে যে আরো 2-3টা সেশন হয়তো হলে ভালো হতো, কারণ এত ভালো পার্টিসিপেশন, এত ভালো কোশ্চেনিং সব ছিল, কিন্তু আপনি নিজেই এটা একটাতে শেষ করলেন। তো আমরা আশা করছি স্যার আমরা ইমেজিং সিরিজ কন্টিনিউ করব, ফিউচারে হয়তো এমআরআই ও আমরা করব, এবং আপনার সাথে তো আমাদের কন্টিনিউশন আশা করি হতে থাকবে। এখন স্যার আপনি আজকের সেশন কনক্লুডিং রিমার্ক দিয়ে আমাদের আজকের সেশন আপনি শেষ করবেন স্যার, প্লিজ।
Thank you, Dr. Ahsan Khan, for the opportunity, and then I would thank BD Physicians for giving me this opportunity. I think stroke is a very important subject, and hopefully I've tried to cover all the practical aspects, and maybe in the near future we can have the sessions on MRI on the brain in stroke and brain tumors and various other sessions as well. Thank you, Dr. Ahsan Khan.
Sir, already